Stand right here. Welcome. Welcome all to the Wolverine Caucus, and welcome to you newcomers, and welcome to you old-timers. We have a wonderful program today on mental health. I was reminded, actually, when I saw Tom, of a great line from Calvin Coolidge, that man of very few words, who went to church one Sunday morning, and his wife was ill, so she stayed at the White House. And Cal came back from the church, and she said, how did it go? And he said it was wonderful. What was the sermon about? Sin. What was the message? Again it. Person with very few words. It's my pleasure to introduce Senator Tom George. Tom represents Kalamazoo in the state Senate. He represents the 7th year in the state Senate, which is, thanks to term limits, his penultimate year in the Senate. He is a candidate for governor of Michigan. He is a physician. He is the chair of the Health Policy Committee of the Senate. Also, I've had the right to lobby him in his role on the Senate Appropriations Committee, because he happens to chair one of the subcommittees that he chairs is on arts and culture, history, museums. He's got a lot of passions, and he's a fine, decent, temperate man in the legislature. I welcome you to the Wolverine Caucus now.
Thank you. Thanks, Craig. Go Blue. I'm here to introduce our speaker today, who is Dr. Kyle Grazier, and she is a professor in the Department of Health Management and Policy and in the Department of Psychiatry at the University of Michigan. Her research has focused on financing of healthcare with special interest in behavioral health, benefit design, and resource measurement. She has received support for this research from several sources, including the National Institute of Mental Health, the National Institute on Alcohol Abuse and Alcoholism, and the Robert Wood Johnson Foundation. She's the author of numerous academic and professional journals, articles, books, and book chapters, and has served as an editor of the Journal of Healthcare Management. She serves on the National Institute of Mental Health Services review panel and on committees for the Robert Wood Johnson Foundation. She's received a BS in Nursing and Biology from Valparaiso University, an MS in Engineering from the University of Notre Dame, an MPH from the University of California, Berkeley, and a Dr. PH also from the University of California, Berkeley. Please join me in welcoming Dr. Grazier.
Thank you for that nice introduction. It's always interesting for me to hear where I've been. It's been so long. So I'm just delighted to be here today to get to talk about something that has certainly been a big part of my career and certainly a big passion of mine, and that is financing for healthcare in general, and in particular for mental health and addiction services. And so what I'm going to try to do in the next 30 minutes or so is to walk you through different pieces of that research and give you some sense of kind of what the prevalence and cost of mental health disorders and addiction disorders are in the U.S. anyway. Talk a bit about how we got to where we are today, and the way I'll do that is by talking about how mental health has been financed over the last couple of hundred years, which, if you're in finance, is how you view most things as being a problem in finance. I will talk about some of the state and federal responses. A lot of the action on mental health has taken place just over the last 15 years or so, and even more recently for substance abuse and addiction services. So I'll talk a bit about that. As we move more into the discussion about the Mental Health Parity Act that was passed last November, I will talk about toxic assets, because if there weren't any toxic assets, there wouldn't have been a mental health parity bill, since it was tucked into that bill. So that's all I'm really going to say about toxic assets. Don't worry about it. And then some kind of issues and expectations that we have with the Mental Health Parity Act. having been passed, and yet there are no regulations for it yet. So just to start, what's the big deal about mental health and addiction services? Well, one of the big deals is its prevalence. If you were to compare mental disorders and substance abuse disorders with other chronic illnesses, you'd find that diabetes, asthma, even heart disease have a lower prevalence than mental disorders and substance abuse disorders in this country. And so it's in some ways almost outrageous that we would ignore these two enormous health problems in this country and yet spend so many resources in trying to take care of some of these other chronic illnesses. And there's a reason for that. There's a history behind it that I'll try and share with you. So the estimates range from anywhere from 12 to 28% in terms of prevalence of mental disorders and substance or addiction disorders in the United States. So that's 1 out of 5 to kind of 1 out of 6 individuals in the United States have some experience with having had or been diagnosed with a mental disorder. Only about 10% of those individuals who have been diagnosed, who have been screened and diagnosed, actually seek treatment. And so we're talking about many undiagnosed individuals whose quality of life suffers from these illnesses, who either don't seek treatment if they are diagnosed, and even among those who are, a very small portion get the kinds of services that they need. Even among the young people in this country, the Surgeon General a couple of years ago, in doing a fairly rigorous study of the U.S. population, these would be youth under the age of 17, that 1 in 5 suffer from a mental disorder, which is it's a very scary thought, both in terms of policy and in terms of kind of quality of life of the U.S. population. If we start looking at the prevalence of bits and pieces or different types of mental disorders, what we find is if you take depression, which is probably the most common of the mental disorders, and severe depression being very common, and you look just among workers, so these are adults in most cases, you find that 1 in 11 workers employed at the time report that in the prior 2 weeks they've been diagnosed or they've been treated for depression. So that's a 2-week prevalence. If we talk about alcohol dependence, we find that if you look over the past 12 months and you try to determine who's been diagnosed with alcohol dependence, now this is a disorder that would be, can you see the screen back there? There's a lot of, should I move it up?
It's not all of the screen, it's the volume that has in front of it.
I can't move those up. But this is when I'm talking about alcohol dependence, I'm talking about a sufficient impairment of your regular activities. So the alcohol abuse is to the point where it impairs your daily activities, would impair your ability to work or impair your ability to go to school if you're a student. And that varies significantly both by gender and by age. And you might not be able to see these numbers, but in the 18 to 29-year-old age range, about 13% of males suffer from, or at least report in the prior 12 months, having been diagnosed with alcohol dependence or having experienced the symptoms of alcohol dependence. And so this is a very this is an age range that's critical to the economy. These are our early workers, and yet alcohol dependence is very prevalent among both males and females, and particularly among males in that age range. The lifetime prevalence of alcohol abuse, when we're talking about alcohol abuse, we're talking about kind of one stage further than alcohol dependence in terms of disability. And this is a lifetime prevalence of this. So I've been using different kind of periods of time. So this would be any time in one's lifetime if you'd suffer from alcohol abuse or alcoholism. It turns out that about 20% of women and about 42% of male report having had experience with alcohol abuse and alcoholism over their lifetime. So we're talking about some pretty significant health issues here. Another way to look at it is